Aloha, everybody. Good afternoon, and thank you for joining our Hawaii Economic Association webinar. My name is Leslie Harvey, Board President of the Hawaii Economic Association. I'm so pleased to welcome HMSA Endowed Chair, Dr. Ruben Juarez, and our very own Colin Moore, who will be moderating this discussion. 3 years since COVID, what have we learned? Heather, can we move this slide forward, please? A special thanks to our event sponsors, HMSA and Hawaii Pacific Health. Your generosity is greatly appreciated, and we thank you for supporting HEA's mission in promoting public awareness and understanding of economics. If your organization, is interested in sponsoring and or collaborating on a future event, please contact us at info@hawaiieconomicassociation.com. HEA members are invited to participate in our Q&A by using the Q&A function at the bottom of the screen. This is strictly a member benefit, and if it's something you're interested in, HEA membership is only $40 for the year. Event resources, including slides and the event recording, will be provided after this event. At the end of today's webinar, please take a moment to let us know how we did via the feedback form. We'll share the link with you at the end, and attendees will also receive this link by email. Now it is my pleasure to introduce you to Colin Moore. Dr. Colin Moore is an associate professor at the Matsunaga Institute for Peace and the University of Hawaii Economic Research Organization at the University of Hawaii. Prior to joining the faculty at UH, he served as a research fellow at Yale University's Center for the Study of American Politics and as a Robert Wood Johnson Foundation Fellow in Health Policy Research at the University of California. He received his PhD from the Department of Government at Harvard University. Dr. Moore has a deep interest in local politics and public policy in Hawaii and frequently provides political analysis for media outlets across the state. Colin, I am going to turn it over to you. Thank you.
All right, great. Thanks so much, Leslie. Well, I'd like to introduce my colleague, Dr. Ruben Juarez, who will be presenting today. Ruben is the UHERO HMSA Distinguished Professor at the University of Hawaii Economic Research Organization and the Department of Economics. He's also the director and co-founder of the Pacific Alliance Against COVID-19. His research interests include microeconomics, game theory and behavior, and network economics, all with applications to health. And he's published in a number of top field journals, including the Journal of Economic Theory, Games and Economic Behavior, Vaccines, and the American Journal of Public Health. Today, he's going to discuss the latest UHERO Public Health Report findings regarding the ongoing impacts of COVID-19, evidence on the role of trust and vaccine hesitancy, the impacts of social networks on behavior and health outcomes, and of course, policy recommendations for the future. So I'd like to turn it over to Ruben.
Thank you, Colin. Thank you for inviting me to share some of the work that we've been doing over the last 3 years. This is, of course, part of a large and growing multidisciplinary team with many of my colleagues at UHERO. Carl Bonham, Tim Halliday, Daniela Bond, at Japsom, Alika Mauna Kea, Meoki Hero, and a large team of more than 20 research assistants and community health workers at PAC and UHERO. Let's go ahead and start. So the summary of the presentation today. So I will cover a brief background on COVID-19, vaccination and needs in Hawaii. I'll move to what have we learned from 2 data hubs that we created during the pandemic, the PAC cohort and the UHERO cohort. I'll describe those. And then finally, some strategies as we prepare for the next disaster of pandemic towards the end. Okay, so all right, so that's an interesting slide. So we've gone through a lot over the last 3 years, multiple COVID variants and the respective surges of these variants. We started with Alpha in 2020. Then the Delta surge in summer 2021, the Omicron in the winter of 2021, and another variant of Omicron in summer 2022. At the same time, several measures and protections have been implemented for our populations. We started with closures of businesses and schools for most of 2020, which had severe impacts, of course, in businesses and the well-being of Hawaii's population. Then the vaccine finally arrived to Hawaii at the end of 2020. The rollout started then. And during this rollout, we realized that a large group of individuals were not willing to be vaccinated. Vaccine mandates were implemented in September 2021, in part because of that. And then booster shots became available, and an even smaller group of individuals wanted to get the booster shot. So all of this obviously happened really quickly. It felt like, every day was a new battle. And of course, the government, business, community organizations had to make decisions almost in real time. So imagine for a second how things could have been different if we had, say, estimations, if we had data available, especially about potential impacts that the pandemic could have or was having on individuals. So imagine if we had the ability during the pandemic to make these data-driven, informed decisions in a rapid way. So for instance, imagine that we were able to look at the effects of business closures from economic, employment, job losses. What are the business needs and how can we support those businesses in need? Maybe who's getting infected by COVID-19. So what are the factors that are affecting vaccine hesitancy? Or how has COVID-19 impacted people in real life? So, if we had this information, state and city governments could have used this data to maybe make a better allocation of the resources that they had. Maybe the response to support of the communities, how they supported unemployment benefits, rent payments, training of businesses, education of community, etc. Maybe healthcare providers, could have put more resources into mental health, okay? I don't know. But I invite you to think about how your organization could have benefited from having more data from individuals and communities in a real-time basis as it was developing. To give you some concrete examples of some of the data collection events that we had throughout the pandemic. Early into the pandemic in fall and winter 2020, we had to set up the infrastructure to do the collection of pandemic impacts for businesses in Oahu. So we did this in partnership with the City and County of Honolulu. So we helped with the Back on the Wave program. I don't know if you guys remember this Back on the Wave, but it was basically an education and awareness building campaign supported by a website, digital advertisement, and public relation campaign. And the site features a directory for the general public to use to look at businesses that are prioritizing COVID-19 safety for their employees. And at the same time that they were signing up, so we actually asked them about the impact that COVID-19 had on them. So we had over 2,000 businesses who signed up for the website, and 1,200 of those businesses completed an economic impact survey, providing valuable feedback for the city and various stakeholders to make, allocation of pandemic funding. So, it took us about 3 months to do this, but imagine if we could have this data in 3 weeks. So at the same time, we had other collection events for businesses. We had COVID-19 mandates. Basically, we look at recommendations for Hawaii businesses, as well as attitudes for vaccination. And then later in October 2021, we look at the efficacy of COVID-19 business mandates, where we evaluated whether the mandates had an impact on businesses, basically. And finally, so we had several publications using mobility data, Department of Health data, et cetera, and that's in Vaccines 2022. But basically the point that I'm trying to make here is that we did all of these data collections. We had to do it on a separate way every time that we had a new data collection. We had to get new businesses, new partnerships to be able to do this. So the infrastructure for the collection of data from businesses was lacking. So, and of course, collecting data from businesses is difficult, but actually collecting from individuals is even more difficult. And this is because, individuals, people have different backgrounds, experiences, language that they speak on. So luckily, we were able to launch several different studies, major data collection, basically strategies. The big one who started in October 2020 and is still going, it's basically funded by the National Institutes of Health, RADXAP initiative, and I'll be discussing about this today. But basically, the goal of that initiative was to address the slow turnaround time on testing, insufficient access to COVID-19 testing, as well as lack of resources for materials for community COVID-19 education. And at the same time, every test was an opportunity for us to collect information about vaccine hesitancy, resistance, and determine some strategies to be able to address that. And then early last year, so we started with what we call the UHERO Rapid Cohort, where we evaluate the impact of COVID-19 in Hawaii's populations. But this is a project that goes beyond COVID, and we are looking at systematically address health disparities in Hawaii, especially providing rapid dissemination of community data to stakeholders. So, and I'll be discussing about this as well today. But again, so this is another example of how the infrastructure for the collection and sharing of data from individuals is still missing, and will benefit from having a more centralized repository for this. So, okay, so that's my introduction. So, if you had to skip the talk or just go to the main text of today's presentation, the learnings about, so we had several learnings about COVID-19 from the PAC cohort. So we identified how factors such as education and information, trust, and consumption contribute to vaccine hesitancy. And this influences decisions regarding vaccination and booster uptake. So this data has informed strategies to address vaccine hesitancy, but really it has helped us document what community already knew before the pandemic, that trust was an important component for individuals to be vaccinated and to take decisions about their health. So increasing trust in healthcare providers, in the government, is an important component to be able to increase the well-being of individuals, and interventions and partnerships that foster trust should be nurtured. And here, so I'll be discussing some interventions that we had with HERO, but also you can think about interventions with other community-based organizations, such as UHERO Oceania, as an example, that targets Pacific Islanders. On the other hand, the learnings that we're going to have today from the UHERO Rapid Cohort, so we're going to be documenting some of the impacts that COVID-19 has had on Hawaii's populations. We're going to be looking at some aspects of mental health, food security, long COVID. And as we enter a new phase of the pandemic, the data basically is telling us that Hawaii's populations are becoming more confident that the worst of the pandemic is behind us, and it's driving, unfortunately, COVID-19 booster uptake down. So significant impacts remain, and this include, long COVID, mental health issues, the prevalence of comorbidities, and these impacts really are important to continue monitoring them. And we have a strategy to continue doing this. I'll discuss that when we get to that. So, okay. So, all right. So this, the first part of the presentation It's entitled Trust and Consumption of COVID-19 Information in Hawaii's Communities. This is a joint work with a large partnership with the UHERO network of health centers that includes the Waianae Comprehensive Health Center, Hamakua Kohala Health Center, etc. So we're going to be presenting that at John Abors School of Medicine, the College of Education, UHERO, Social Sciences, etc. This is funded by the National Institute of Health RADXUP initiative. Okay, so in Hawaii, so we're taking a deep breath. So finally, we are not seeing as many cases as we had during the pandemic, or at least we are not detecting them with the usual ways, PCR testing. But when we started the pandemic, so we know that there was a large effect on mortality, and there was a large effect on cases. And so to give you an example, Native Hawaiian and Pacific Islanders in December 2020, so this is the first 9 months of the pandemic, they represent 21% of the population, but they were 18% of the cases. As of February, that's about 20% of the cases. That's almost even to their population share. But Pacific Islanders, unfortunately, had a disproportionate burden of COVID-19 cases. So they make up 4% of the population, but when we started the pandemic, they make 27% of the infections. Right now, they are making about 6%, which is great. It's a huge decrease, right? Filipinos, 16% of the population, 21% of the infections at the start of the pandemic. Now it's about 16%, so it's almost impaired with the population. So, and this obviously had what reflected in mortality data. And Native Hawaiian Pacific Islanders had a disproportionate burden in mortality, and over the last months actually is becoming even. But Pacific Islanders in particular, so they make up 4% of the population again. Right now, 14% of the deaths due to COVID-19, and this is mainly because of the start of the pandemic. So, and we know that disparity in infectivity and mortality, at least in the first part of the pandemic, was due to gaps in vaccination. So overall, Hawaii has been doing very well in vaccination relative to other states in the nation. So as of last month, almost 80% of the population had been vaccinated, yet significant gaps remain, especially in age, ethnicity, and region. Younger individuals have significantly lower vaccination rates. Native Hawaiian had one of the lowest vaccination rates in the nation. So it started at 13% of the vaccination rate in Hawaii. Now it's 22%, which is Native Hawaiian Pacific Islanders, which is great. A large increase, which is what we want to see. And then these disparities in COVID-19 include, are obviously higher prevalence of pre-existing conditions, which implies increased mortality due to COVID-19, gaps in vaccination coverage, and increased infectivity. So some of the reasons that we encountered when we started this project was that there was a slow turnaround time for getting COVID-19 testing results. So actually, when we set up the infrastructure, we started seeing COVID-19 PCR tests being shipped to the mainland, especially for underserved communities, taking 1 or 2 weeks to be able to get the results back. So there was an insufficient access to COVID-19 testing, lack of resources, materials for community COVID-19 education, vaccine hesitancy and resistance, and really an incomplete understanding of why some individuals are more at risk than others to develop severe long-term consequences of COVID-19. So we invite you to visit our website. It's www.paac.info for more information about some interventions that we have. I'm gonna quickly give you a glance of them just in this video. which describes basically the project. PAC is part of a national consortium funded by the National Institutes of Health RADXAP initiative to increase COVID-19 testing capacity and uptake in underserved communities.
PAC has enabled us to put together a really innovative partnership between multiple entities. This includes federally qualified health centers, including the Waianae Coast Comprehensive Health Center, the Hamakua Kohala Health Center, Bay Clinic, Molokai Health Center, and the Waimanalo Health Center. In addition, we partnered with the Department of Education, charter schools, as well as the Department of Health and community members in each of these communities across the islands.
I oversee the testing unit of PAC, where my role is to help build capacity for community and school-based testing and assist with interventions to increase the uptake of health services to mitigate the spread of COVID-19. In addition to this, we recognized early into the COVID-19 pandemic that communities we have worked closely with for years have already experienced health disparities and would be more vulnerable to severe COVID-19.
Underserved communities in Hawaii, including those composed by Native Hawaiians, Pacific Islanders, and Filipinos, are shown one of the largest disparities for COVID-19 in the nation. Our team created a new model of testing at schools that was piloted at Kamaile Academy.
When initially approached to partner and do COVID testing at Kamaile, my first reaction is, let's do it. We have the flexibility, we have the autonomy as a charter school, but the real decision was about what's right for our school community to keep our kids and staff safe.
The type of test that we're doing here is a rapid antigen test, and the two types of tests that we're doing are the Abbott Binax Now and also the BD Veritor.
I think the PAC program and the partnership that we have between Kamaile and PAC is really strong, and I for one personally want to continue to be able to be tested. I want to know that I have that safety, and I want to go into next year with more assurances that things will be normal, and testing is one really good way to make sure that that happens.
It's preventative measure. So we can come, we can gauge how are we doing in our own communities with our own families, if we're keeping safe. And it's a good way to monitor. That's why I do it every week, and this is my third time.
It's been really important that we have accurate data during a pandemic so we can make the decisions at our school level. This type of data around COVID testing for our staff is just one more example. This data helps us to make decisions so that we can keep our kids safe and focus on learning, and our staff feels comfortable so we can focus on learning.
In parallel, we recognize that eliminating disparities must involve education. As such, we work with schools not only to test, but also to educate teachers and students. Our team developed a new COVID-19 curriculum that we hope teachers can deploy in the fall. We see teachers and schools as assets in preventing the spread of COVID-19 in Hawaii.
It's always been our belief that the more you can empower students and teachers to have the knowledge to take control over some of the various streams of information that are coming in, that you will have a better control over health. You'll have a better understanding of what is a reliable source of information. So you can go to the modules. We have two different forms of how you can learn about the modules and teach from the modules. One is by videos, and each is about 15 minutes, and the other one is through a PowerPoint presentation. So we're really looking at students and educators in general being able to be collaborators and partners with our public health.
The COVID-19 pandemic has had a huge impact on communities across Hawaii, but we are certain that by bringing together partnerships to address the disparities, to get people tested, to keep people healthy and safe, that we're going to be able to get through this together.
All right, so that's basically a description of our project. Building this multidisciplinary project took a variety of partnerships, as Alida was saying, not only 3 colleges at the University of Hawaii, but also 5 federally qualified health centers in 3 islands, the Waianae Coast Comprehensive Health Center, Waimanalo Health Center, Bay Clinic, Hamakua Kohala Health Center, and Molokai Health Center. It includes the Department of Health, the Department of Education, and over 15 schools in the state around these health centers. So one critical piece of the study is that each test represented an opportunity for us to engage individuals in the community and collect data. So our PAC data hub that we built collects data on over 100 standardized variables longitudinally. So as of last week, we had 343 testing events done, almost 50,000 tests conducted in partnership between UHERO and PAC, and over 16,000 individuals. 65% of those individuals are Native Hawaiian Pacific Islanders. So we had several projects to date. I'm not going to be focusing on all of them. I'm just a narrow set on vaccine hesitancy, but we've produced over 12 papers and reports as part of PAC. So vaccine hesitation in the state of Hawaii. So data from the CDC early into the pandemic was already telling us that the top reasons for vaccine hesitation in Hawaii, similar to data nationally, are concerns about the side effects and distrust in vaccines. A less common reason among Hawaii adults is distrust in government. However, this data does not reflect ethnic and racial differences in underserved communities. So one of the hypotheses that we had is that the social influences and the degree of trust and consumption of information underlie vaccine hesitancy. So to test this hypothesis, we aim to examine the association between trust and consumption of COVID-19 information, assess the degree to which this association vary by race and ethnicity, and determine how this association relates to vaccine and booster uptake. So we collected information from, so for this paper, we collected information longitudinally from 1,600 individuals statewide during the vaccine rollout. And then we stratify individuals on 3 categories. So we have those individuals who are early adopters. So these are individuals who, vaccinates within 2 months of eligibility. We had individuals who we call late adopters, those who waited to get vaccinated, 3 to 6 months, but they got the vaccine at the end of the day. So this is basically hesitating individuals, but they got the vaccine. And then non-adopters, those who refused to be vaccinated after 6 or more months to be vaccinated, or they only did it because they were forced due to a mandate. So we get this information actually from the survey. And then on the right-hand side, so what you can see is how education, consumption, and trust in official and unofficial information associates depending on the group that you are. So for instance, individuals who are early adopters, so they have a higher level of education than say late adopters or non-adopters. Whereas like individuals who are also early adopters, the blue ones, so they have higher levels of official trust. And we're gonna go over this today, actually. I'm not gonna be discussing the data, but basically, this is a representative data from our cohort. Everything is published. The left-hand side of the screen actually has a paper. This is one example of how we collected trust. This is a question that they always ask us. So it's on a Likert scale, basically. So we ask different levels of information, faith leaders, doctors, and then on a scale of basically 1 to 5, you tell us whether you trust this source of information to provide correct information about COVID-19. And then we have different sources of information, right? And then we semi-quantify these variables. I'm not going to go over these, but just to give you a quick example, for the trust index, so we put it on we normalize it between 0 and 1. Basically, closer to 1 means that you trust a lot this source of information. Closer to 0, you don't trust. And then we have these 2 indexes, so the official trust index and the unofficial trust index. And then the official trust will include things like government trust, doctors' trust, official sources of information, such as the TV, news, media, etc. And then the unofficial trust index will include things like faith leaders, family and friends, people around you, social media, of course. And then finally, the education level is also normalized between 0 and 1. Higher levels means that you have a higher level of education. Lower levels, basically between 6th and 8th grade, is 0. So for the first research question, so we look at how does education, trust, and consumption of COVID-19 information affect vaccine hesitancy. We use a proven regression to estimate the probability that an individual, basically when an early adopter, late adopter, or non-adopter of the vaccine. And then we're doing a comparison between early adopters and everyone else. And we're going to be doing a comparison between late adopters and non-adopters using this regression model. So to give you, some of the results, the table basically evaluates how early adopters, the table on the left, early adopters differ from everyone else. So we find that an increased probability of 60% from being an early adopter if an individual has an advanced degree rather than just completing 6th to 8th grade. Or equivalently, an average of 10% increase on the probability of vaccination for every year of school past 8th grade. In addition, note this coefficient of trust in official information. This is basically telling us that there is an increased probability of being an early adopter by 61% if the individual increases his level of trust in official sources from not at all to a great deal of trust in official sources. Similarly, note the coefficient in, not that actually this is not significant for unofficial information. So basically, what this is telling us is that at least the correlation that of being an early adopter is actually correlated with official trust, with official consumption, as well as education level. Okay. On the other hand, if you look at the table on the right, so this is a comparison of late adopters with non-adopters. Okay, so think that we are in the middle of the pandemic. 3 months after the vaccine is being rolled out, and the Department of Health is wondering, well, what can I do to increase vaccination? Okay, of people who haven't been vaccinated at this point in time, and then we see that official trust is an important component. So we see that coefficient to be significant. And then we have unofficial trust. Okay, so these individuals are more affected by unofficial trust. In fact, unofficial trust has a decreased probability of vaccination by 25%. Okay, so if an individual moves from not trusting to fully trusting, basically as source of unofficial information, and then official consumption actually was significant. And one thing that is important here to note is that education was no longer significant, at least not at the level, 95% level. So basically those individuals who hesitated are actually not affected by the education level. Okay. So, and here actually we break it down even further by looking at the specific sources of information. This is the 95% confidence interval for those sources of information. So for instance, government, doctors' trust, print and online media, COVID-19 task force, they all positively influence or are positively correlated with getting the vaccine for those early adopters. Education was also an important component for that. And then if you look at like late adopters versus non-adopters, so again, so we have government, doctors, the COVID-19 task force that affect vaccine uptake for those late adopters versus non-adopters. But then we start seeing that unofficial information was significant, right? So COVID-19 faith leaders, people around you, basically your social networks, whether you get information from them, is affecting vaccine uptake. And education, okay, was no longer significant, and if anything, was actually negatively correlated. So trust is a determinant for vaccine uptake. How about for booster uptake? So we also have information in the paper about this. So we look at how those attitude changes in trust and consumption of COVID-19 information affect after the first 2 doses of booster hesitancy, similar model that we had. And basically, the findings here is that late adopters who got boosted had an increase in trust in official sources, no changes for early adopters. And this basically tells us that there is a mechanism behind that, right? So early adopters had already a large level of trust, and as soon as they were eligible to receive the booster, they got it. So there is nothing to do with them. But late adopters who hesitated initially, maybe they didn't trust the vaccine was safe or heard bad things about the vaccine or side effects, and that was a source of hesitation while they waited. And you know, once they got the vaccine, they realized, you know, it's not as bad as they originally thought. So their trust in official sources increased, and they went ahead and got the booster shot when they were eligible. So no changes for unofficial information. Okay, so basically the takeaways from this first part with PAC is that we identify factors such as education and information trust that contribute to vaccine hesitancy and influence decisions regarding vaccine uptake over the course of the COVID-19 vaccine rollout. Education is no longer important for decisions of vaccine uptake after 2 months of hesitation, and the government needs to pay effort and focus on increasing the official trust and consumption of people. And the paper reveals this association between these longitudinal changes on official trust and consumption, which are helpful for booster uptake. And there is a lot of translation to public health policy. I'm going to be discussing this later, but working with our community partners to share the learnings and increase trust is actually an important strategy to do this. So, okay, so I'm going to, since kind of, I'm going to move to the UHERO Public Health Report, go really quickly, and then we're going to leave this open it for questions. But, you know, early, just to give you an example of early in 2022, we started developing the infrastructure at UHERO to inform the design and execution of public health programs in the state of Hawaii and addressing health and socioeconomic disparities. So the rapid survey that we deploy is quickly and efficient way to collect data from individuals on life disruptions and other socioeconomic factors. And the flexibility of the survey allowed to measure, you know, household experiences during disasters and recovery, providing nearly real-time information for decision makers to make the most, you know, at the most critical times. Okay. You know, through linking with proprietary data set hosted by UHERO, things like housing or partnerships such as HMSA, we're hoping to link data collected to produce a more comprehensive insight into a representative sample of Hawaii's population that can ultimately support data-driven decisions in the state of Hawaii. So the initial cohort was funded through the American Rescue Plan via the state of Hawaii. We recruited 2,200 individuals as part of a panel. This is all across the state of Hawaii. A subset of individuals are contacted about every 2 months, at least once per semester. We have a pretty high retention rate of about 80% of individuals. So we collected 40 variables longitudinally. These are updated regularly to include the most pressing issues in the state. It includes demographics, vaccination, attitudes toward testing, trust, but also health effects, income effects, employment effects, housing effects, mental health, etc. And the goal is to, as I was mentioning, is to eventually match it with outside records. So in terms of the midterm goal, so we're trying to increase this infrastructure to 5,000 individuals, have a more connected data that can inform stakeholders within 7 to 10 days since we start the data collection, and have an advisory board who can help us shape the type of questions that we should be asking. The sample size, as I was mentioning, is 2,200 adults, 1,600 that we have follow-up information. The baseline was collected in May. The follow-up information in November, close around November of last year. And just to give you an idea of some of the main findings is that, COVID-19 positivity has increased since the last report. In November, so 45% of respondents had a positive test for COVID-19 at least once during the pandemic, compared to only 25% in May. So higher rates continue to be seen among younger individuals, Native Hawaiian, Pacific Islanders, Filipino populations, as well as those unvaccinated and unboosted individuals. And this is a very critical information because at-home testing right now is basically the norm for testing. So getting a PCR testing is not something that people really do right now, unless ordered by a doctor. So COVID-19 infection is not typically reflected in data from the Department of Health. So getting this survey out allows to see whether there is an increase on the number of COVID-19 infections. At the same time, so we know that Hawaii has one of the highest adult vaccination rates in the country. That's a big success for Hawaii. The overall vaccination rate is over 95%. Unfortunately, only 27% of our sample has received the bivalent booster shot. In addition, only 10% of adults under 50 years old have received the bivalent booster shot. Native Hawaiian and Filipino have the lowest booster uptake in our sample. And then signs of COVID fatigue are present in Hawaii's populations. So the highest levels were found among those unvaccinated and those vaccinated without booster shots. The lowest scores were seen for those with booster shots and older adults, which may explain the bivalent booster shot uptake. Respondents had a more optimistic view of the pandemic in the fall compared to the spring. So in May, 75% of the people said that the worst of the pandemic was over. This increased to 86% in November. And to give you an idea, let me see if we have the results of the survey today. Heather, do we have the results to see how this compares to our?
We do. Let me put the link in.
Okay. There's something. Okay. Let's take a look. So yeah, basically, yeah, very similar to what we are seeing, right? So the worst of the pandemic is behind us. So 77% of the population, or of the attendance actually, have you received the bivalent booster shot? Wow, 83%. That's actually, that's not what we see in our data, right? So basically we have a sample that doesn't agree with our, and then is COVID-19 over for personal life? 23% are saying yes, 77% are saying no. So, which also is telling us that we have a more biased sample. So, okay, which is expected, right, from this audience. So, okay. So one of the big findings of the May UHERO report, the first one that we released, is that almost 2 in 3 adults have been negatively impacted by COVID-19. And I don't have time to go over all the impacts, but just to give you an example, so having their savings depleted was one of the main impacts. Troubles with childcare, unable to pay bills, getting furloughed, unemployed was a big one. So another impact that the pandemic had is obviously on food security. So 1 in 5 individuals had food security issues in the state, and this was significantly larger for unvaccinated individuals than vaccinated individuals. And this obviously has to do with the type of individuals who are getting vaccinated versus those who are not getting vaccinated. 1 in 3 adults reported symptoms of depression in the state. So similarly, depression was higher for unvaccinated individuals as well as those who had actually were experiencing symptoms of mental health. And one of the things, so we're actually working right now on a report that studies specific contributors and determinants of mental health in this cohort. So we're able to see how those unemployment or food insecurity is associated with mental health outcomes. Depression is one of the outcomes that we measure. Self-esteem, so 11% of adults reported low self-esteem, lower self-esteem again for unvaccinated individuals. And 4% of adults reported serious suicidal thoughts, and this is higher for unvaccinated individuals as well. In terms of long COVID, so we measure long COVID based on CDC guidelines of having persistent symptoms 30 days past infection. The prevalence of long COVID remained high at about 30% of infected individuals, the same rate as in May. And this rate is actually the same rate that the CDC has nationally. More individuals reported severe or very severe symptoms in the fall compared to the spring. Mental fog and headache became the most common symptom in the fall, with 59% of them reporting them. And the expected length of symptoms increased to 4.5 months post-infection. That's about 1 month more than what we had in May. And we are also one of the first to report that long COVID is associated with unemployment. So we are seeing that despite the rate of long COVID being about 30%, unemployed individuals had a 47% rate of long COVID. That's a 5% increase since May. So again, so this is only an association. This is not causal, but we're trying to build this longitudinal cohort to look at those effects. So, as we enter a new phase of the pandemic, I mean, the main takeaways of the UHERO report is that Hawaii's population are becoming more confident that the worst of the pandemic is behind us, driving COVID-19 booster uptake down. However, significant impacts exacerbated by the pandemic, including long COVID, mental health issues, and the prevalence of comorbidities are expected to continue imposing challenges that we should continue monitoring. So where do we go from here? We're going to continue. We're hoping to continue following up and growing this cohort to make it more representative of the state, including more minorities, disabled individuals, homeless populations. Future reports will focus on the cause of COVID-19 and long COVID in Hawaii. We're working with HMSA, hoping that we're able to access a limited health records, basically, especially claim records, to be able to measure that. Mental health is another important part. So we're actually working on a report right now specifically on mental health. The impacts of housing and health, and the impacts of disasters such as volcanic eruptions in health is part of our report that we are looking into. And in general, focusing on systemic issues affecting the state. And we're hoping that this will allow us to get the infrastructure ready in case of the next pandemic or disaster happens, and report results promptly to decision makers, partners, and community. So the overall policy implications for the next pandemic, I mean, the long-term vision that we had before the pandemic and that we continue having post the pandemic is that we need to continue cultivating trust and empower communities with data, education, and solutions to improve their health and well-being and reduce disparities. So trust in government and other official sources was a determinant for COVID-19 vaccine and booster uptake, and interventions and partnerships that foster trust should be nurtured. Despite significant challenges posed by the pandemic, the infrastructure and partnership laid out to support COVID-19 mitigation efforts should be leveraged to continue getting and collecting this data. And that's where we are right now. As we prepare for the next pandemic or disaster, we are looking for partners, support, to really build this infrastructure and plan it so it's able to inform decision makers. So mahalo to all our partners. Some of them are here. To learn more about this, all the UHERO reports are on the UHERO website, my website, or the PAC website for the intervention. Thank you.
Great. Thanks so much, Ruben. Well, I think we're ready to take some questions. So we have a few, but feel free to add to that list. And since we're the Hawaii Economic Association, I'll start out with a question about the financial implications. So Ruben, what do we know about the cost of COVID in Hawaii? And is there an estimate of its cost to the state's economy?
So no, basically there is no estimate that we know. We're working with our partners, as I mentioned, specifically HMSA, and we're hoping to recruit a few more to develop one using medical claims record. There are some narrow estimates that have been done at the national level, putting the cost at up to $16 trillion with a T. Okay, so if you believe those estimates, and just do a simple division based on the population of the state of Hawaii, we'll end up with a cost of like $67 billion for the state. This is likely an underestimation, of course, since Hawaii was more severely impacted than other states due to the reliance on tourism, longer closures, etc.
Great, thanks. We have a couple of questions that I think you partially addressed in the presentation, but I'll ask them anyway. So this is really about how we can trust the counts, the COVID counts, with most people taking home tests and likely, of course, not reporting it. So why do we still use these case counts as a measure of COVID levels when hospitalizations might be a better measure?
Yeah, because, okay, so first of all, I don't think that people are using those counts, and that's what it is. Definitely important to know how many individuals are infected, and how many individuals have been infected, especially to look at potential disparities that may happen. So once you look at a hospitalization metric, that's something that has happened. It's like 3-4 week delay. By looking at COVID counts, you are able to more effectively, rather than wait for people to die or be hospitalized. Having said that, okay, so yeah, so the reliance on data from the Department of Health, which typically uses PCR testing. I mean, of course, it's not accurate anymore. Like everyone is using COVID-19 antigen testing. And that actually, I think, is a better metric. And that's why surveys like us allow us to do this counting, at least to look at how many individuals have been infected.
Let me ask you a question about misinformation and disinformation that's come through social media. And you've shown this in the presentation. Is there a specific social media channel that your data showed affecting vaccine hesitancy the most? And how do you think we can address this misinformation and disinformation presence in social media?
Yep. So, yeah, that's a good question. We saw some differences across social media channels. I don't believe they were too different from each other, to be honest. They were mostly different due to the number of users. There is more users on Facebook, and the type of users. Older adults use Facebook rather than Instagram or TikTok. So yeah, so we definitely saw that Facebook was a large source of misinformation, mainly among adults. Large number of children in our PAC cohort was seeing misinformation through TikTok. So that was a component. So in terms of strategies for reducing misinformation and disinformation, as far as I'm aware, I don't think that there is a specific intervention in Hawaii that focuses on reducing them. I've seen several examples in the mainland where you use trusted community-based organizations, partners, to disseminate information. So think about like the Department of Health partnering with community organizations to disseminate valid information. This may be a good strategy for Hawaii. I hope so. But basically, I don't know if this has been tested or not here.
Well, we have another audience question about trust. This comes from Chris Haig, and I'll read it. How much is trust dependent upon public information on the many public health science successes in the past? There appears to have been a deliberate omission of normative public health information education in the history of its many successes, which disturb the level of trust in the population. So should there be more research on what source of information for public health sciences were used to improve trust? So I think the core of this question is, should there be more work or should we be better at publicizing all of the success that public health interventions have, and have some of their failures sort of eclipse the many successes?
Yeah, and I think that we should, and I honestly think, I mean, so as soon as we saw the results from, for instance, our PAC cohort, I mean, on trust, I mean, we sent this to the Department of Health. They've been using this information, of course. So yeah, so I think that there is not enough research done in trust. There is not enough really to disentangle what are the effects that trust and consumption of information have on, vaccine hesitancy is really is one example, but it's more than that, right? It's like, do you go to the doctor? Do you get the flu shot? Okay, so what we started seeing actually, so that UHERO, so we didn't have it in the PAC cohort, but in the latest UHERO report, we started asking questions about flu shot. Did you get the flu shot? Who's getting the flu shot? The people who's getting the booster shot. So these type of strategies are super important. And they are being, unfortunately, affected by trust. So I don't think that there is enough research done in this topic.
Let me ask you kind of a big picture question, which is, what do you think the state of Hawaii can be doing now to get ready for the next pandemic?
Wow, that's a big question. So yeah, I think that I touched some of these points at the end of the presentation. Set up a sustainable data collection and sharing infrastructure is really important. Cultivate trust in official information sources, government, doctors, healthcare providers. I mean, how do you cultivate trust, right? I mean, so, developing this trust with community-based organizations, maybe educating individuals at schools can be a good way. And some of the PAC intervention that we have actually was targeting that. Actually, we have initial preliminary data that is showing us that intervention was able to increase trust of individuals. It's an educational intervention. Actually, we partner with teachers. We train them on how to, what is a good source of information? How do you find them? How do you communicate this to children? And then the teachers go to their classroom and teach that to the kids, right? And we're able to compare whether the individuals at this classroom got the vaccine or the individuals trust more information than those classrooms that were not treated with that intervention. So yeah, I mean, I think that this type of strategies on education, strategies on linking with community organizations that are trusted members of the community are really important to develop this trust. And as I was mentioned, I mean, we really need to set up a sustainable data collection and sharing infrastructure at the state government. I think that right now, we started that with the UHERO cohort. The funding is going to expire, by the way. So I don't know if we're going to continue past the summer. But our goal is really to increase it, make it more representative of the state population, and we're looking for partners. We're looking for funding to be able to do that.
You sort of alluded to this, but as you know, of course, the federal government announced the end of the emergency declaration that's going to happen in May. So what do you think happens when the declaration ends? What are going to be the effects here in Hawaii or nationally?
That's a question for the people. Yeah, so basically the people in the healthcare sector, among others. But So I don't know the exact consequences, basically, but from the top of my mind, individuals will have to pay for their vaccine, test, and treatments. That's the basic ones that basically will go away. This will likely affect people who don't have insurance. Luckily, Hawaii, a large proportion of individuals has insurance. It's one of the states where we have a high insurance rate, health insurance at least. But those people who don't have insurance, I mean, some of the Pacific Islanders, I mean, my colleagues have been reporting this for a while, will likely be affected. And especially, this probably will affect the most underserved populations in the state. So that's basically the bottom line.
Great, thanks. I don't have any more questions from the audience. Is there anyone who would like to ask something? All right. Any last words or thoughts you want to share, Ruben?
No. I think that thank you so much for the invitation again, and feel free to reach out if you have any questions about this.
All right, great. Thanks so much. I'll turn it back to Leslie for some final thoughts.
Thank you both. Appreciate that. Looks like we're done a little early today, folks. So I'm just going to close us out here and we will get you out of here. Please be sure to complete the feedback form. And thank you everybody who's tuned in today. Thank you, Colin, our moderator, and Dr. Ruben Juarez. And thank you to Reen Kamita and Heather Walters, who facilitated much of the behind the scenes coordination. Thanks to our returning attendees and to those who are joining us for the first time. A special thank you to HMSA and Hawaii Pacific Health for your sponsorship of today's events. As mentioned just a few short weeks ago at our last webinar, we have a great lineup of virtual, hybrid, and in-person events this year, so stay tuned. Don't forget to complete that feedback form. And thank you so much for joining us. As you know, we strive to make our events relevant and beneficial to Hawaii's diverse business community by tackling topics that are pertinent and breaking them down to make them more accessible to a broad audience. We hope that you found this to be the case today, and we look forward to your feedback. Thank you so much for your time and attention. Dr. Ruben Juarez, thank you. I know we tried to have you on right as COVID was starting, and so I'm glad that we were able to have you back, particularly for this topic. It was a great fit. Thanks very much, everybody. Have a good afternoon.
Thank you.